going to be talking about croup, which is a general term that's applied to a broad classification of upper airway illnesses that result from swelling of the epiglottis and the larynx. It's a group of conditions that's characterized by that inspiratory stridor, harsh, brassy, or croupy type cough, hoarseness, and varying degrees of respiratory distress. Most of the time, it's caused by parainfluenza viruses, and the types of croup include the laryngotracheal bronchitis, acute spasmodic, and bacteriotracheitis. The one that we're going to talk about that's the most common is the laryngotracheal bronchitis. The next slide gives you a picture of the pathophysiology of croup, how the mucus becomes inflamed, mucosal inflammation of the larynx and the epiglottis, and there's edema that narrows the airway. So there's that sudden onset of harsh metallic type cough, inspiratory stridor, hoarseness. They're in respiratory distress, which can lead to substernal or suprasternal retractions, agitation, pallor, cyanosis, which then leads to the different symptoms of increased heart rate, extreme restlessness, and then that leads to hypoxia. So this gives you a good picture of how the normal airway, the normal larynx is, and the trachea compared to the child that has croup. I don't want you to pay attention to the epiglottitis at this time. We're going to do epiglottitis in the spring, but know that croup often begins at night and may be preceded by several days of symptoms of upper respiratory tract infection. The child that has laryngotracheal bronchitis may have a gradual onset and a fever along with other signs and symptoms. And occasionally that fever can go as high as 104 degrees. So we can have that use of accessory muscles, frightened appearance, agitation, and that cyanosis that you'll see. On diagnostic evaluation, it's basically observation of any kind of clinical symptoms. They do have some physicians may use a Croup score as they look at the child, and also look at the oxygenation status. On therapeutic management, the goal is to maintain a patent airway. Children with the acute type of spasmodic croup can usually be cared for at home. The ones that have laryngotracheal bronchitis are usually, because this is usually a more severe type of croup, are often hospitalized than those with the other type of croup. Racemic epinephrine nebulized with O2 may be given to decrease the laryngeal edema and the bronchospasm. The child has to be observed very closely when they are given epinephrine, because it's very, very temporary, and they may have a rebound stridor, so they're kept in the emergency department for at least 3 hours after treatment and shouldn't be discharged if any stridor or retractions are present. We'll also use oral dexamethasone, which is the drug of choice for to decrease inflammation, and antibiotics are not indicated unless a bacterial infection is present with that. So on our nursing care, let me go over here to this side. Our nursing care of the child with croup, make sure that you do a really good history, and usually it reveals a recent upper respiratory tract infection. Assess the child for any respiratory, inspiratory stridor, barking, cough, hoarseness, increased heart rate, respiratory rate. Record any kind of signs of respiratory distress, the use of those accessory muscles, substernal, intercostal, and suprasternal retractions, any nasal flaring, restlessness, irritability, pallor, or cyanosis. Anytime that you see cyanosis, increased heart rate, respiratory rate, that extreme restlessness or evidence of fatigue or listlessness, those are all signs of hypoxia, and they should be reported to the physician immediately. So we basically, in our nursing diagnosis, ineffective airway clearance related to mucosal swelling and obstruction of the upper respiratory tract, risk for deficient fluid volume related to inadequate oral intake and tachypnea, and fear related to dyspnea and hospitalization. So we want to make sure on our interventions, we want to facilitate airway clearance. You have to monitor the child's breathing continuously for signs and symptoms of increased respiratory distress, increased respiratory rate, stridor at rest, nasal flaring, those retractions, cyanosis, change in level of consciousness, increased irritability, decreased or adventitious breath sounds. That's important. The child must be kept as quiet as possible because crying may aggravate laryngospasm and increase hypoxia. We also want to maintain fluid balance, so we have to monitor the child's hydration status with I&O. Check the mucous membranes, see if there's presence of tears, weigh the child daily on the same scale and at the same time of day. Make sure that you offer fluids, but they need to be at room temperature. And always observe to see if the patient can swallow, because tachypnea and laryngospasms often will cause dysphagia. Monitor your IV fluids in your child and monitor the child's temperature at least every 4, and give acetaminophen or ibuprofen as ordered. Make sure you decrease the fear. Make sure that you maintain a calm, restful environment. And if they're going home, they've been in the ER and they're going home, we want to provide teaching to the parent of the signs and symptoms of respiratory distress and symptoms that should prompt a call to the physician. Always make sure that you emphasize the importance of adequate hydration, nutrition. A humidified environment may also help increase the child's comfort. And just remember that cough syrups and cold medicines are usually avoided because they can dry and thicken the secretions, and we need those thinned out with the fluids that we give.